In this video, we would like to demonstrate the surgical basics for the management of anal abscess. This video is produced by Dubai Colorectal Surgery Unit in Dubai, United Arab Emirates. In the remainder of this video, we'll demonstrate the fundamentals of draining an ischioanal abscess. The primary goal of incision and drainage is to control the sepsis and obtain relief from the pain. This operation is deemed as simple surgical procedure and in training centers is often assigned to the most junior member of the surgical team. However, it is important to note that proper drainage can determine the future outcome for the patient. The most important basics of dealing with acute anal abscess is adequate drainage for the abscess to avoid immediate failure of the procedure and the need for the early return to the operating room for re-drainage. Due to the close proximity of sphincter muscle, it is important to protect the sphincter and avoid any potential damage. For patients with first-time anal abscess, the likelihood of developing a chronic fistula is over 65%, and for patients with recurrent sepsis, an established fistula is often present. Determining the site of the incision is key. The area of most fluctuance needs to be accessed for proper drainage. Staying lateral to the sphincter muscle is critical to avoid damage while at the same time avoiding too lateral of an incision to shorten any potential fistula tract. Start by gentle palpation for the area of the most fluctuance and determine the lateral edge of the sphincter muscle. Make a stop incision to access the cavity. A cruciate incision is advisable to ensure adequate drainage at the skin level and avoidance of premature closure of the skin. Culture the pus as there is an increasing incidence of resistant bacterial organisms including community-acquired Maher A, resistant E. coli, and vancomycin-resistant enterococcus. Irrigate the cavity and consider gentle curettage, especially in the patients with recurrent abscess. A 1.5 cm cruciate incision is performed. Drain and culture the pus as it flows out of the cavity. Milk the pus out. Irrigate the cavity with betadine. Excise the skin flaps of the cruciate incision. Irrigate again. And do the proper curettage. It is always important to remember that main goal is to drain the acute abscess. Dealing with the anal fistula in this setting is controversial. Often a fistula cannot be identified due to the amount of the tissue inflammation. However, if a fistula is readily identified, a consideration should be made for the placement of a draining setton. Fistulotomy is rarely advisable in this setting. Pratt B valve is used to inspect the anus. Betadine injection through the abscess cavity to see if extravasation from an internal opening and if fistula tract is readily identified, consider the placement of a draining setton. After achieving proper drainage, hemostasis is achieved with a combination of electrocautery and cavity packing. Local anesthetic is injected for postoperative pain control. Hemostasis is obtained externally by cauterizing the edges of the skin incision. The cavity is then packed with the ribbon gauze dressing, which is kept in place overnight. The postoperative use of antibiotics should be reserved for patients with significant cellulitis, high fever, or immunocompromised and diabetic patients. The packing is removed by the surgeon or the patient if discharged the same day. No repacking is advisable as it is often very painful for the patient. Sitz baths with gentle wound irrigation and pain control is prescribed. Anal abscess is one of the most common colorectal emergencies. Incision and drainage can yield significant relief of the pain and control of the sepsis. Observing the basic fundamentals described in this video would hopefully lead to a successful outcome for the patient with minimum morbidity. Thank you.